On a de bons internes. Alors nous allons passer maintenant à l'homme de la situation, William Boisseau.
We have good student doctors in France now, William Boisseau. Well, we have good doctors to be, but we also have good corticoids. Good evening, everybody. I'm a bit late, so I have to put in my USB key. It's just going to take a couple of seconds.
Ça a l'air de marcher, c'est déjà une bonne nouvelle. Donc, je me présente, je m'appelle William Boisseau.
Well, it seems to be working. That's good news. My name is William Boisseau. I'm a junior doctor in oncology, so I'm going to introduce to you the clinical case of a patient we had. Our service deals with brain tumors, and we are dealing with the complications induced by cancer treatment. She's quite young. She's 27 years old. Our colleagues diagnosed her in May 2014 with renal carcinoma with a translocation TFEB, keeping in mind that during diagnosis the disease was already at metastatic stage, lung, retroperitoneal, lymph nodes. The diagnosis was confirmed. Then there were several therapeutic treatments, as you can see on screen. All these treatments, I mean, Votrient, Afinitor, were stopped. Here is a picture of a scan. We reached the third therapeutic line. Here you see metastasis here, some mass, and here an adenopathy. It was decided in January 2014, given the progression, to go for chemotherapy with IPILIMUMAB every 3 weeks from February to May 2015. This chemotherapy triggered a clear response. Here we see a strong regression of lesions. It's not that simple, nevertheless. Here you had pictures of her control scan, but she's had other problems that started at the beginning of June. She lost visual ability bilaterally. The IMR shows enhancement of optic nerves, but also lumbar nerve roots problems. Here it's IMR problem. We see a hyper signal of the optical nerve. We see a contrast along the path of these two neurological of these two nerves. And here we can see also the roots of the nerves on this MRI scan. First lumbar punction shows lymphocytes issues. So we go for corticotherapy, 1 gram per day over 5 days, which enables clear improvement. So she's recovering almost 100% of her visual ability, but she has pains that are difficult to describe in both her legs, and once again, a decrease in her visual ability. CMRI, no modification, and we're trying not to miss any differentiated diagnosis, but you see some tumoral cells. So we think that maybe we didn't give enough time to the corticoids. So we decide to go for oral corticotherapy with 1 milligram per kilo. Improvement is quite needed. She came to us, she was almost unable to walk. Improvement is quite quick. She becomes autonomous again, but she lost her Achillean reflex. The electromyogram confirmed some radicular changes, and things improved slowly through MRI. We see a decrease in the size of the edema, no tumoral cells, as you can see, for LP3. We have a neurological table which is quite concerning, with progression after corticotherapy. So there's a decision to intensify the treatment and gone with corticotherapy. We had from July to August, or even to September, 10 cycles. Clinically, she remained stable. The MRI's results improved. So we have clinical stability. With all these treatments, we have a clinical aspect that's quite satisfactory, as her vision went on improving. And our fear was that all these treatments that are quite invasive didn't impact the anti-tumoral response. As I showed to you in September, the results were quite satisfactory. So here you have a summary of the various tests. Globally, everything was normal, so we thought it was more meningoradiculitis with bilateral optic neuropathy associated with IPILIMUMAB. So that's it. Thank you.
Since I was the one that mentioned reintroduction of the immune checkpoint inhibitor, that was in a very different scenario. I think these patients, I think, at least I have not reintroduced patients, and this is anti-CTLA-4 antibody, which is much more likely to cause these types of reactions. So we've unfortunately seen fatal cases of myasthenia and other fatal disorders really from this. You did an excellent job managing this patient, that she's still alive today. That's wonderful. And it sounds as if she's not received further CTLA-4 antibody, but still remains stable from the cancer perspective.
It brings up the question that we don't know is do we need to continue these therapies? If we're just looking at the therapeutic aspect, how long do we need to? What's going on that might have benefited from plasmapheresis late into the course? And even if you cease the therapy, it sounds as though without the supportive care methods, you're still getting major toxicities. Per?
This just is a continuation of our first case discussion, basically. These tremendous good drugs that the side effects really are beyond our scope, basically. We pretend to understand some of the mechanisms, but we don't know. And again, corticoids release, which sometimes is anti-intuitive, because as you mentioned before, there's some not good anti-CL4A, but good anti-PD-L1. If the tumor is infiltrated, it's their prognosis to response. if the lymphocytes do not penetrate the tumor, it's not going to work, is the consensus right now. So this just tells us that we modulate the immune system, but we don't know exactly how it works. It's very fine-tuned how it works. And I'm very concerned. I have a patient, I recall, a French guy, in my hospital with colitis, and we gave it corticoids, and corticoids was like cholera, but I mean like water for 1 month. And we ended to give anti-TNF-alpha. And 2 days after I started anti-TNF-alpha, the guy died, but didn't have for the anti-TNF-alpha. It's because the guy was completely emaciated. So sometimes the immune system just goes wild. You cannot really, we don't go corticoids daily, you know. Another problem you can face with this guy is that you give so many corticoids, you're going to get into a myopathy. Then the guy is not going to be able to walk. You're going to start thinking maybe neuropathy. No, it's the corticoids, so watch out with that.
Other comments about this difficult and interesting case?
May I? What was the reason of the plasmapheresis?
C'est une bonne question. C'est vrai qu'au final, on se retrouvait, alors je ne vous ai pas mis tous les chiffres par la suite, mais on se retrouvait, alors certes, elle s'était améliorée sur ses douleurs, mais elle avait encore une acuité visuelle qui était quand même loin d'être parfaite. Elle avait encore des difficultés.
Sorry, we had an improvement in terms of her pains. Her sight got better. She was responding well to her anti-cancer treatment, but we thought that her quality of life was also important, and we felt like giving her the greatest possibility to improve her eyesight and therefore to fight side effects. We've done some work in terms of, we had an analogical approach, for instance, inspired by patients with multiple sclerosis who were dealt with in a certain way. So that's how we approach plasmapheresis. Yes, the approach was more analogical than based on data.
I think our neurologist would recommend plasmapheresis as well. So I think it's it's an empiric therapy, as the steroids probably are, but I think,
It's last resort.
But it,
It's a last resort.
but it was associated with, well, I think it's a resort after steroids, because you just mentioned that the chronic steroid becomes an issue. So I think our melanoma colleagues are trying to move faster to other interventions. So TNF-alpha in patients with severe colitis, our melanoma people will move to that within a week or two rather than continuing that. So I think we have a lot to learn on management of these patients. And then I think the other thing our melanoma colleagues have done is they're trying to figure out how to give the least amount of ipilimumab. So they're using PD-1 agents first and then adding a few doses, but not trying to make that the maintenance therapy because of cumulative toxicity.
Well, very often plasmapheresis is treatment of the physician, you know.
You have a question?
So we are seeing that there is increasing use in different malignancies of adding ipilimumab to another checkpoint inhibitor. And we will see, we are not sure what the effect on survival is, but we know that there's added toxicity, so it could be even more complicated.
But response also, but increased response.
And increased response, but we're not certain yet what the survival effect is. Other questions from the audience, or comments, or experiences to share? We have 1 or 2 minutes. Well, thank you very much. It's really another interesting